Good evening, everyone. Greetings on behalf of World Anesthesia Day, on behalf of the NCSI e-education panel, we would like to welcome you all to this session on rapid ICU rounds. The topic for discussion today is acute ischemic stroke and its intensive care management. So the rounds will be presented by two presenters. The first presenter is Dr. Shanmuga Priya, who is a senior resident from Department of Neuroanesthesia, JIPMER. And the second presenter is Dr. Mohammad Sali. He is senior resident from the Department of Neuroanesthesia and Neurocritical Care, AIMS, New Delhi. And the moderator for this session is Dr. Manish Marda. Sir is Director, Neuroanesthesia and Critical Care from Medanta, Noida. So welcome you all to this session, and I'll hand it over to Dr. Manish. Good evening, sir.
Good evening. Today we are going to discuss two cases of stroke. So that I would request Dr. Priya to present the first case.
Okay, sir. First case, a 70-year-old gentleman presents to the ED at around 4 p.m. He came with complaints of inability to move the right arm since 2:30 p.m. He has comorbidities of diabetes and he is on oral hypoglycemic agents. His vitals are blood pressure of 190/110, pulse rate of 95 per minute, saturation of 92 on room air, temperature of 99.6. Patient is conscious and responds to commands.
So that to make a summary, this patient arrived yesterday and you managed the patient yesterday. So how did you assess the patient and how did they manage the patient, acute management of the patient in the ER? What were your
First, when the
priorities
patient
for
came
this
to
case? Yeah, what were the
First, when the
priorities
patient
for
came to
prevention?
ED, I assist ABC, sir, airway, breathing and circulation and disability, sir. In airway, the patient was able to talk, so I came to know that his airway patency is maintained. In breathing, his saturation was only 92%, so I had kept oxygen so that his saturation is maintained over 94%. In circulation, this BP and heart rate, pulse rate was around 190/110, and GCS and pupils I checked, sir. GCS was around some 14, sir. Then after that, I checked did one quick history taking with sample history, sir. In signs and symptoms, I mainly asked when was the time the patient was last seen normal, and the patient had presented within 1.5 of onset, sir. Then A is for allergy, then M is for medication, especially cardiac medication or any anticoagulation if he had taken, I had asked, sir. Then L is last meal, E is events related to insult, sir. Then I quickly assessed NIHSS score, sir. In our patient, it was around some 4/4, sir. And after that, I immediately took RBS, sir, to check blood sugar, stroke mimics, sir. And then parallelly I secured 2 IV cannulas and sent investigations, complete blood count, renal function tests, electrolytes to rule out other things, and coagulation profile. Without waiting for that report, immediately once sugars was normal, I immediately shifted the patient to radiological imaging, sir.
So you want to say that the only investigation that you wanted to have in your hand was blood sugar level, and you would not wait for the rest of the reports to go ahead, isn't so?
Yes, sir. On examination,
Okay.
I checked for pulse, sir. There was no any arrhythmias. So in case if there was any arrhythmias, I am suspecting any cardioembolic, means at that point of time, I would have taken ECG and echo would be another investigation, sir. Since my patient was normal, I immediately shifted the patient to NCCT after RBS, sir.
Okay. Do you think you need to go for echo at this stage?
If clinically there is no any past cardiac history events or no any cardiac medication and there is no arrhythmia, we can no echo is also not required, sir. Just with RBS, we can shift the patient to CT, sir. Parallelly, one CT, if after CT, we can proceed with the other evaluation, sir.
Okay, excellent. The blood pressure of this patient was very high at this point of time. It was 190/110. Do you want to treat the blood pressure at this point of time?
Sir, initially I don't want to rapidly reduce the BP because in case patient is having acute ischemic stroke, the high blood pressure will help in diffuse the region, sir. So once after NCCT, that patient is either a candidate for thrombolysis or mechanical thrombectomy. At that point of time, my target would have been less than 185/110, sir.
Excellent. So that it means that blood pressure reduction below a certain point should be done if we are planning any intervention in the form of thrombolysis and thrombectomy, isn't it?
Yes, sir.
Okay. Then what was your next step?
Sir, in NCCT we did, sir. It was normal, sir. So, and patient was not having any contraindications for thrombolysis, sir. And there was no any hemorrhagic changes also in NCCT. So, we decided to proceed with the thrombolysis of the patient, sir. Then we shifted the patient to monitoring unit. We got consent from the patient. And then after that, we decided to thrombolyze the patient with the tenecteplase, sir. 0.9 mg per kg. We gave IV, sir. After thrombolysis, within after 1.5 hours, patient improved asymptomatically, sir.
Okay. Suppose the patient did not cooperate for imaging, then what would you have done?
Sir, first I will assess why the patient is not cooperating, sir. If he is very anxious because his right upper limb is not moving, just because of anxiousness, means at that point of time I'll give mild sedation like either Dexmed or Propofol so that his airway patency is maintained. But if I feel that patient is having any bulbar symptoms or patient is not able to maintain the airway patency or patient is not cooperative, patient is not able to maintain immobility for the procedure, and if I'm suspecting any posterior circulation stroke, at that point of time I would prefer to secure the airway and then shift for imaging, sir.
Okay, so that the most important thing is to prevent the loss of time.
Yes, sir.
So if we can done CT straight away, we should do. And if we need to do or need to give the sedation to get the imaging fast, then we may have to. We should not hesitate in giving sedation, so that we should not waste the time. Okay. So you said that there was no contraindication for this patient for thrombolysis. So what were those contraindications which we looked for?
Sir, in NCCT, we should rule out there is no any hemorrhage, sir. Then the blood pressure should be less than 185, 110, sir. Apart from that, there should not be any intracranial space occupying lesion. Patient should not have any coagulopathies, especially not on any anticoagulants. INR should be less than 1.7. Platelet should be less than 1 lakh. And in case of any APTT, more than 40 seconds. PT more than 15 seconds, and patient is having in last 3 months any history of stroke, MI, or any major surgeries, any aortic dissection or aneurysm, or a patient having active bleeding tendencies, GI bleedings. In such cases, I will avoid thrombolysis, sir, and infective endocarditis also, sir.
Yeah, excellent. Why with infective endocarditis?
Because in that case, the treatment will be antibiotics, sir. It is cardioembolic rather than the primary thromboembolic, sir.
And there are very high risk of rebleeding if we give thrombolysis in such patients. Okay,
Yes,
you
sir.
told me that NIHSS score was, what was the
Four,
score?
sir. Four, sir.
Okay, what would you what did you make out of the this score?
Sir, it is minor stroke, sir.
So what is the
It,
significance of this score in the management of stroke?
So it helps us to assess the grade the severity of stroke, sir. It has around 11 domains, sir. A score of 1 to 4 is minor stroke, 5 to 15 is moderate stroke, 16 to 20 is moderate to severe stroke, more than 21 to 42 is severe stroke, sir. Based on this, I can assess the severity, and also if the treatment modality will change, sir, and prognosis also is made, sir. If the more severe the stroke, the prognosis chance is bad, sir. And if in case of the decision making, if the NIHS score is more than 6 or 7, we can in case of it is a higher grade of NIHS scoring, we can directly plan for mechanical thrombectomy, because large vessel occlusion can be one of our differentials, sir.
So what are the levels at which you will go for thrombolysis or thrombectomy?
Sir, if patients presents to the ED within less than 4.5 hours and there are no contraindications for thrombolysis, at that point of time we can go for thrombolysis, sir. If patient presents beyond 4.5 hours, that point of time a mechanical thrombectomy can be considered, sir.
And regarding NIHS score, does it help us to make a decision? Like when would you not like to thrombolyze this patient depending upon NIHS score?
Sir, NIHS more than 7, sir. 7 to 25 mechanical thrombectomy we can.
Okay, then we go ahead with this case. So then you show the CT and then you thrombolize the patient. Okay,
Yes, sir.
then how will you monitor? Or suppose the patient would be taking or was taking warfarin, then how what will you do? Like if the INR is high, PT is high, INR is high, then what would you do?
Sir, if patient is taking warfarin, first I will ask when was the last dose of warfarin taken, and I will check INR, sir. Since INR is high, I would not proceed with thrombolysis, and my primary plan will be directly mechanical thrombectomy, sir, since it comes under contraindication of thrombolysis, sir.
Okay. And you said that your patient improved with thrombolysis.
Yes, sir.
And what if the patient did not improve with thrombolysis?
Sir, after thrombolysis, I will send the patient to CT angio, and I will check if there is any large vessel occlusion, and I will plan for mechanical thrombectomy to bridge the thrombolysis with mechanical thrombectomy and proceed further, sir.
Okay. Are you aware there are some extended time window criteria for trials are there for thrombectomy?
Yes, sir. We have diffuse 3 trial, which tells we can go for mechanical thrombectomy from 6 to 16 hours. And dawn trial, it tells we can proceed with the mechanical thrombectomy from 6 to 24 hours. And we should also see the core penumbra ratio, sir. The mismatch ratio should be more than 8. There should be a small core and there should be a large salvageable penumbra. If the penumbra is large, means we can go for mechanical thrombectomy, sir. That we can find out using MR perfusion, sir. It tells us information about mean transit time, cerebral blood flow, and cerebral blood volume, sir. In case of core, the mean transit time will be more prolonged when compared to that of penumbra. Based on this, we in DWI we can see the core. In MR perfusion, we can see the penumbra. If the penumbra is large, we can still have a salvageable penumbra, and we can still proceed with the salvageable procedure for an extended time period, sir.
Okay. Uh, do you have any other imaging for the patient? Do you want to show me the MRI
Yes,
which you did?
we have an MRI, sir. The first image shows DWI scan of the patient, sir. It shows it is an axial view in the bifrontal region, T2 weight image, and it is showing hyperintensities in the left frontal region, sir. The second image is a flare. Flare is comparatively normal, sir. So there is a difference between mismatch between the DWI and flare sequence. So probably if DWI is positive, the patient has presented within 4.5 hours, sir. In case we have any wake up stroke or any stroke where we don't know the exact time of presentation, if we have an MRI in hand, we can still proceed with thrombolysis because flare changes appear on a later period beyond 6 hours, sir. And the third image is showing MR angiogram, sir, top sequence. In that, there is left side, there is some uh, loss of filling at level of M2, sir. M1 is filling, M2 there is no filling, sir. Probably M2 cutoff is seen, sir.
Okay, so there is another very pertinent and very important question. What blood pressure levels will you treat in the patients pre and post thrombolysis?
Sir, before thrombolysis, my BP cutoff will be less than 185 110, sir. During and after thrombolysis for 24 hours, I would like to keep the BP less than 180 by 105, sir.
So it is very important to see. Suppose the patient's blood pressure is around 110 or 120 millimeter of mercury, systolic blood pressure. Then what would you do?
Sir, we can augment the blood pressure, sir, because if less than 120, there is chance of cerebral ischemia, sir. At least we should keep less than 140 also is acceptable, but it should definitely be more than 120, sir. The recommended range may be around 140 to 180 we can keep, sir, about that.
So it is slightly controversial thing because it also depends upon the baseline blood pressure of the patient. So you need to consider that also. If the patient is having normal blood pressure baseline and is having hypertension now or slightly lower blood pressure now, then you need to augment the blood pressure. But the patient's base blood pressure is also the same, then you need not to augment the blood pressure.
Okay,
Okay.
sir.
So
Okay,
these
sir.
limits which you are saying like 185, 110 or 180 by 105, those limits are to treat the hypertension if the patient has. Okay. So there are no clear criteria when you should augment the blood pressure.
Okay, sir.
Okay. And what will be your blood pressure levels when the patient is not for thrombolysis?
If patient may be presented beyond 24 hours, in that case, my BP target, I'll allow systolic BP of up to 220 by 120, sir. Because
Okay.
to allow perfusion for the ischemic penumbra, sir.
Okay. And how do you decide whether you should go for GA or MAC if the patient is posted for thrombectomy?
Sir, yeah, first I will ask for duration, sir. I will assess patient's cooperativity for staying still for the procedure and whether he'll be able to still stay immobile or not. Then I will assess patient is having any bulbar symptoms or not. He's able to swallow, cough, gag, everything is normal. Means I will proceed with the max, sir. In case if there is any posterior circulation stroke or cranial nerve deficit or patient is having any difficulty in swallowing, in such cases I would prefer to secure the airway prior and then I will proceed with this thing, sir.
Don't you think
Proceed.
that GA will waste the precious time,
Sir,
and it
if
will also?
rapid sequence intubation is done by a trained anesthetist, it will hardly take very short time, sir. In MAC also, if in case intra we find that patient is not cooperating properly, that can also delay time. And in between, if we have to secure airway because of any bulbar symptoms in between, that also will waste more time, sir. In that case, prior itself giving GA in a rapid sequence induction is won't take that much time, I feel, sir.
Yes, definitely. I also agree with you that the patient is not cooperative. It is better to give GA, and that will actually save some time for you. When the patient moves, the whole sequence has to be done again. So that wastes time. So that is the right way of doing it. Okay,
Yes, sir.
okay. Then how will you monitor these patient post thrombolysis? Like you did thrombolysis, so that how would you monitor the patient in your ICU?
Sir, after during and after thrombolysis, I will mainly monitor for GCS pupils, sir. Then blood pressure monitoring, sir. For first every 15 minutes for first 2 hours, 2 to 8 hours every half an hourly, 8 hours to 24 hours every hourly. I'll monitor blood pressure. Apart from that, we can watch for Cushing's reflex, signs of raised ICP, headache, vomiting, any seizures, and parallelly we can use non-invasive mode of raised ICP monitoring like ONST, TCDs for checking for any reperfusion, then pupillometries, then this monitoring can be, apart from the glucose monitoring, normothermia, normoglycemia, this also needs to be monitoring, sir. In case patients develop any drop in GCS deterioration after ruling out stroke mimics, I will again shift the patient immediately to CT because hemorrhagic transformation immediately post thrombolysis will be my first differential, sir.
Okay. So, so many times we say that we should not insert any invasive lines, or we should not do a puncture in first 24 hours. Then, do you think that we can insert invasive lines or draw samples after thrombolysis in first 24 hours?
Maximum we should try to avoid, sir, because post thrombolysis the bleeding risk will be high. Whatever investigation needs to be taken, we'll send prior to thrombolysis as well with two IV lines, sir. In case of any emergency, like a patient is having any hemorrhagic transformation, where at that point of time you want to know the coagulation profile, fibrinogen level. At that point of time, unless emergency, we should not put any invasive lines, sir. We should try to manage. We can try to manage with peripheral lines, whichever we had secured prior, sir, and feeds also through Riles tube in case the patient is not swallowing well properly. That also needs to be placed before thrombolysis, sir. Riles
But
tube Foley's or
if we have
invasive.
not inserted during, like, suppose the IV line which you put now it is not working, okay, then what will you do?
Sir, this will come under an emergency situation, sir. That point of time, carefully we have to secure one more IV line only, sir.
Yeah, so
So unless
peripheral
emergency,
veins can be cannulated without much difficulty, and if
yes,
required, they should be cannulated. But
yes, sir.
arterial punctures, what we mean by invasive line is arterial puncture. They should be avoided, or the places where we cannot give compression, those should be avoided.
Yes, sir.
Okay, because many a times the nursing staff or the doctors, even doctors, they say that we cannot do anything because there is high risk of bleeding. There is high risk of bleeding, but if need arises, we have to insert invasive lines also. Okay.
Okay, sir. Yes.
What are the stroke mimics which you want to rule out, or
Sir,
which you
first
can
one
think
is
of?
hypoglycemia, sir. That's why we check RBS immediately once the patient comes to this thing. Apart from that, seizure can present as Todd's palsy, sir. Then migraine with aura can present like stroke, sir. Then any intracranial space occupying lesion with hemorrhage can present like stroke. And also electrolyte disturbances like hyponatremia, hypokalemia, they also can mimic stroke, sir.
Okay, and what do you prepare? Like if the patient has ICH or other systemic bleeding after thrombolysis, then how will you reverse the coagulopathy?
Sir, first I will reduce the BP, sir. Then after that, I will give cryoprecipitate to reverse it, sir. Parallelly, I will send for a fibrinogen level coagulation profile at that point of time. Around 10 unit cryoprecipitate I'll be giving, sir. Then tranexamic acid 1 gram I'll give. Then in CT, if there is any midline shift or increased edema, then at that point of time, I'll start trials of reduction of ICP. I'll start head neutral, head elevation, then give hyperosmolar therapy, either mannitol and 3% saline. And I'll even inform neurosurgeon consult in case any decompression is required, sir.
Okay. Okay, that was a nice and very good case presentation, and it was a very well managed case. I think we should go for the second case. Dr. Selly,
Yes,
are you ready for the this case?
yes. So I'm
Okay.
presenting a case of a 65-year-old female who presented to ED at around 7:30 a.m. Patient had complaints of inability to move the right arm and right leg since 5 a.m. as she woke up from sleep. And patient had complaint of difficulty in speaking since 5 a.m. and patient presented with altered sensorium since 6:15 a.m. Regarding comorbidities, patient is a known case of rheumatic heart disease since 40 years on medical management. The vitals of the patient were blood pressure 170 over 90 mmHg, pulse rate 115 per minute, which was irregular in rhythm, SpO2 of 96% on room air, and the temperature was 99.6 degree Fahrenheit. The Glasgow coma scale of the patient was E2, M5, and B1.
Okay, then how did you manage this patient? Initial management of the patient in the ER.
So the initial management of the patient in the ED, like I considered ABC approach, airway. For this patient, the patient had altered sensorium and a 4 GCS of 8. So for this patient, I had to secure the airway by performing intubation, and I had to start on the mechanical ventilation for the patient. Regarding the circulation, the patient's pulse rate is high and the rhythm was irregular, and the patient's blood pressure was 170 over 90. My target for this patient was blood pressure of less than 185 over 110 mmHg until further evaluation has been done for the patient. And for disability, I'll do a quick capillary blood glucose to rule out hypoglycemia, which is a common mimic for stroke for this patient. And for temperature, like I will maintain the temperature of the patient less than 37 degrees Celsius, since hyperthermia is associated with poor outcome in patients with stroke.
Okay, then once you did the initial stabilization, what did you do?
Sir, this patient last sign known was not known. The patient was found to be abnormal as she woke up from stroke. So in this case, I would like to go for an MRI, sir. So I have done MRI for this patient.
Can you show the
Particularly,
MRI? Okay.
so the first image is the diffusion weighted imaging of brain, which is taken at the level of lateral ventricle. Here we can see the left MCA area showing the hypo intensity, showing the diffusion restriction. The next is the flare image of the same sequence at the same level, but it is not showing any lesions. So there is a diffusion weighted imaging and flare mismatches there. This indicates that the patient might be presenting with in the window period, which is the 4.5 hours of the infarct period, and the patient is eligible for reperfusion therapy. And the third image is the MR perfusion imaging, in which there is a mean prolongation of the mean transit time, reduction in the cerebral blood flow, and the normal cerebral blood volume, which might indicate that the ischemic penumbra is present. And the last image is showing MR angio, in which left MCA vessel cutoff sign is seen. So based on the imaging, I can make a diagnosis that patient is having left NCA territory stroke, which is well within the window period. So the patient is eligible for further reperfusion therapy.
Okay, this patient was already having RSD. So was this patient on any anticoagulant?
Uh, Sir, the uh, patient detailed history was not elicited at this point in time. Um the patient rhythm is irregular rhythm, sir. So patient could be in atrial fibrillation, and most likely patient could be on warfarin, which the history should be have been elicited, sir.
So should you wait for PTINR if you want to thrombolyze this patient?
Yes, sir. In this patient, there is highly chances that the patient's INR is elevated, and if we go for thrombolysis, there is high chances the patient might end up in hemorrhagic transformation, sir. So in this case, it might be reasonable to wait for coagulation parameters before going in
Yes.
for IV thrombolysis.
And you should also take history in the sense
Well,
that the patient may be on newer anticoagulants or direct oral anticoagulants.
yes, sir. So coagulation workup including platelet count, PT, INR, APTT have to be done quickly to rule out coagulation parameter before proceeding with the IV thrombolysis, sir. Since the patient's rhythm is also irregular, a 12-lead ECG can be taken to confirm what rhythm, especially atrial fibrillation rhythm, is there or not in for this patient.
Okay, what is your suitable reperfusion strategy for this patient?
Sir, if the coagulation parameters stand to be normal, the patient can undergo both thrombolysis, IV thrombolysis, and the endovascular therapy. Since there is MRI imaging which is showing mismatch, so the patient was thrombolyzed with tenecteplase 0.25 mg per kg, and simultaneously the patient was taken up to the cath lab for endovascular thrombectomy for large vessel occlusion retrieval.
What is the advantage of tenecteplase over alteplase?
Sir, the advantage of tenecteplase is that it can be given as a single bolus dose without any requirement of giving further infusions, sir, as opposed to alteplase, in which the first 10% is given as IV bolus over 1 minute, and the rest dose is rest 90% is given for next 1 hour of IV infusions.
Okay, so do you think that there was an extended time window for thrombectomy or endovascular treatment for this patient?
Yes, sir. Generally, the standard thrombectomy window period is around 6 hours, and the trials like diffuse 3 have shown 6 to 16 hours, and drawn trial have shown 6 to 24 hours of extended window period for patients who have selected patients who have large vessel occlusions.
Okay. Now you shifted this patient to ICU. Okay, then what will you tell the ICU nurse to follow or to monitor in the patient? Because it is very important to monitor the patient very closely and aggressively in post procedure period.
Yes, sir. So the general ICU monitoring, which include heart rate, blood pressure, pulse oximeter, respiratory rate, and all the vital parameters, including temperature, blood glucose, has to be monitored, sir. Specific instruction for the patient: blood pressure monitoring and the control. Post thrombolysis, the target of less than 180 mmHg over 105 mmHg has to be maintained. Blood pressure above which should be treated, and blood pressure had to be monitored in a certain frequency, so like every 15 minutes for the next 2 hours, every half an hour for the next 6 hours, and every hour for the subsequent 16 hours. So the blood pressure management within the first 24 hours is very crucial for this patient, sir. And during this time, and the nursing orders, I will also specifically instruct that no invasive lines such as the placement of Rayleigh tube or placement of any invasive arterial or the central line should be avoided for these patients, sir. Normoglycemia of a target of 140 to 180 should be maintained. Fever should be avoided, and hypothermia as well as should be avoided. Normothermia should be maintained for this patient, sir. And the neurological parameters such as the Glasgow Coma scale and the pupils have to be monitored for the patient. Any symptoms such as patient's decrease in sensorium, nausea, vomiting has to be monitored for this patient sequentially.
Okay, suppose your patient deteriorated or developed new neurological symptoms, then what will be your differential and how will you go ahead?
Sir, my differential is that the patient have undergone IV thrombolysis. There could be a hemorrhagic transformation, or there could be a chances that the reperfusion therapy was not effective, and the patient's infarct size is increasing. So there could be chances of malignant MCA infarct in this patient as well, sir. These two I have to rule out.
Then how will you treat the raised ICP in these patients?
Yes, sir. So general ICP reduction measures such as head-up position, avoiding hypercarbia, like maintaining the normocarbia, and ensuring the patient is having adequate analgesia and sedation, neck neutral position should be ensured, sir. And also to reduce ICP, osmotherapy can be considered using mannitol or hypertonic saline. Mannitol with a dose of 20% mannitol of 0.25 to 1 gram per kg. With, and also hypertonic saline can be considered if there is hypovolemia in this case, with a target sodium of around 145 to 150 milligrams per liter can be done for these patients.
And when should we go ahead with decompressive cranectomy?
Sir, if the CT shows malignant MCA territory, in fact, which is usually defined as more than 50% of the territory of the MCA has developed infarct, and if there is presence of midline shift of more than 5 mm, and if there is any signs of herniation syndrome in the CT, and if there is progressive worsening of the GCS of the patient, then decompressive craniectomy has to be done, sir. So I'll inform the neurosurgeon and arrange OT accordingly, and I'll shift the patient for emergency decompressive craniectomy.
Okay, one last question. This patient was already having atrial fibrillation, so you have to restart anticoagulation in some form. So how will you go about that? And suppose the patient will also need to provide DVT prophylaxis. So what about the anticoagulation part?
Sir, regarding the anticoagulation for the patient with acute ischemic stroke with atrial fibrillation, AHI guidance says 1, 2, 3, 4 rules. So one is that patient with the transient ischemic attack after 1 day of having the event, after ruling out the patient is not having any risk of hemorrhage, can be started on anticoagulation. And based on the NIHS score, less than 8, 8 to 16 and more than 16, mild, moderate and severe stroke, any other possibility of increased risk of bleeding or the hemorrhagic transformation has been ruled out with further imaging such as CT or MRI. Then for the mild stroke on the day 2, moderate on day 3, and for severe stroke after day 4, the anticoagulation has to be started, sir. And these patients are at high risk of developing DVTs further, since they develop immobility in their limbs, and they might be expected to stay in the ICU for a prolonged period. So DVT prophylaxis has to be initiated in terms of mechanical prophylaxis as soon as the patient is admitted into the ICU through sequential compression devices. Regarding the pharmacological prophylaxis, once the patient is made sure that a risk of rebleeding is risk, uh, the surgical hemostasis have been achieved and the further bleeding risk is lower. Usually like 24 to 48 hours later, based on the institution protocol, we can start the patient on DVT prophylaxis such as low molecular weight heparin or unfractionated heparin as deemed for the patient.
Yeah. Thank you so much. You both managed your patients very well. And I think that we covered most of the questions that usually are asked, or there are queries regarding the acute management of the stroke in these two cases.
Thank you. Thank you, both the presenters. It was an excellent presentation, and the questions were answered in a very crisp manner. And I thank Dr. Manish for moderating this session and giving a thought-provoking discussion. And since the theme of this session is basically finishing the early management of stroke, intensive care management of stroke in 30 minutes, we would like to wind up the session. And you can follow the YouTube channel and subscribe, and the recording will be available in it for future purposes. On behalf of NCSE Education Committee, I thank everyone for this opportunity. Thank you.
Thank you.